Okay, Tom, I'm going to assume the live stream is properly live. Are we?
You are live.
We are live. Okay, wonderful. Well, thank you all for being with us at, again, a very opportune time, given recent events in the news. And the purpose of today's session of the All-Party Group on Coronavirus is to explore some of the issues around test, trace, isolate, or indeed find, test, trace, isolate, and support, as we prefer to try and call it in the APPG. And we have two panels this morning. The first panel is with us already and will go until 12:15. And then the next one will also be 45 minutes, starting at 12:15. But in this first panel, we really wanted to focus in a bit on the impact on frontline staff. You know, what is happening right now on the ground, and also to reprise some of the conversations that we'd had previously. So it's a real delight and a massive thank you to Mark Adams, CEO of Community Integrated Care, Judy Downey, Chair of the Relatives and Residents Association, and Professor Andrew Goddard, President of the Royal College of Physicians. Thank you all for coming to us again and giving us evidence, giving us a bit of an update of where things are now. And I'll crack on. So to begin with, and I'll come to Mark first and then Judy and then Andrew. How well is it going now compared to how the system was operating, perhaps as a comparison in July and August? How is it comparing to how it was before? Mark.
Okay, well, good morning, and it's very nice to be with you again. I think that if I look back to sort of August and September, we were sort of relieved that finally we had testing being done proactively. We weren't having to wait for people to be symptomatic. We did have this intention of weekly testing for care staff on the front line, and obviously monthly testing for residents. I was checking the figures, and in August we were having about 40% of the tests for our teams hitting the 2-day target. By September, that had dropped to about 10% hitting the 2-day target, with the worst cases being 10 days that we were waiting for test results to come back. As of this week, we're looking at around about 30 to 40% of tests hitting the 2-day target. The average is 3.5 days, and the worst case is 6 days. But you can imagine that, you know, well over 6 months into this, the staff are very weary. They're very anxious that there's an increasing amount of pressure to allow home visits to be starting again with families. We know there's high instances of community carried infection, where something like half of our services are in local lockdown. So we're in a situation where people are really at the moment just hoping that the system can get on top of this, because frankly, waiting for longer than 2 days is too much.
Thank you so much, Mark. Judy Downey.
Hi. I'd kind of echo a bit of what Mark said. Sorry, I ought to say thank you for inviting us, and delighted to be giving evidence again. Certainly in the summer, things seem to be improving. They weren't brilliant, but they seem to be improving for care homes. Now we seem to have gone backwards. The explanation seems to be the impact of schools, universities, and those pressures. And also the fact that various members of the care home staff who were not, as it were, delivering personal care, but had supervisory jobs. For example, you know, if you were running, say, 20 homes, you have people who visit the homes and make sure that practice is as it should be, that staff are coping, that the normal supervisory managerial roles. And those people have now been refused tests on the grounds that they don't have a hands-on function, and that if they exhibit symptoms, of course they may have a test, but if they exhibit symptoms, they have to isolate for 2 weeks. So it seems a very topsy-turvy sense of priorities in that sense. And the delay that Mark referred to seems to have been pretty ghastly in some places. There are some places where they haven't had the test from last week back before the next one's due, and even longer than a week. The idea that residents are tested, it seems to be somewhat mythical in a lot of places. And even where relatives are offering to have tests and pay for them, that's a very hit and miss business. And also some homes are not accepting tests not done by the people who do it for them. So it's a very mixed and pretty upsetting picture, frankly.
Thank you very much. Very concerning. Professor Andrew Goddard.
So good morning, everybody. I think our situation sort of is slightly different from that, because I'm talking about sort of NHS physicians generally working in hospitals and secondary care. So back in July, 88% were able to get a test within 24 hours. That's fallen to 80% last week. And back then, 36% were then getting their results within 24 hours, and that's fallen to 26%. However, there is a caveat to that, because of course things have changed radically. The number of people being tested back in July was about 4 times fewer than it is now. And the return of school has meant that lots of, particularly doctors with young families, have ended up having to self-isolate because they've got children or household members who have been sent home with symptoms. And so the demand for testing in those household members is much, much greater than it was in July. So I think we are comparing apples with pears slightly, but clearly there is significant delays.
Thank you very much. Lord Russell.
Yes, just sort of following on from what each of you have just said, and if I could ask you to respond in the same order, can you just dig a bit deeper and tell us some practical instances of the knock-on effects of this very sort of sporadic performance in terms of A, getting the tests, and B, how quickly they're coming back? What are the actual practical consequences of that? Can you sort of bring it to life a bit? Mark.
Thank you, Lord Russell. I mean, I think first and foremost, it's the anxiety of the teams and the families, because the only thing that gives you certainty is accurate and timely testing. We've had instances where we've had results back after 10 days and they've confirmed that a member of the team has had COVID, and they know that for the last 6 or 7 days they've been providing close contact care, and then you're just playing the waiting game hoping that you haven't passed that infection on. And that's just completely unrealistic pressure on people that are very tired at the end of this period. You obviously have families who are desperate to now start coming in and visiting, and I think everyone will have seen the Amnesty report and the commentary on this. The only way to do that is to start testing families as key workers as well as the staff. And given that the staff ratio is normally about 1 member of staff to something like 5 residents, you'd potentially be looking at a 5 or 6 times increase in testing. And when the testing isn't working on the current demand, this is a kind of Herculean task that you're then reaching for. In addition to this, we've now got the extra pressure of team members being told that their children are being sent home to self-isolate because the schools have got an issue. And therefore you're losing staff, not necessarily due to the environment they're working in, but the outside environment. And then if you're trying to move new staff in to cover for the staff that are ill, and you can't get the testing back, again, you're worried that you're transferring someone into a home and you're going back to the March, April, May scenario where we saw so many losses. So, test, and just to give comparison, I mean, for my sins, I used to run a lab group in the Middle East with 16 labs. That lab group now is handling most of the COVID criteria for large parts of the Middle East, and they're working on a 4-hour turnaround. So literally you can get a test before you fly. So for us to be in a situation where we're looking at 10 days, I mean, it really is dark ages in comparison.
Judy, could I ask you the same question, please?
Yes, I think that Mark's put it very well. I think that, words like severe anxiety could also be replaced by anguish, depression, bereavement, and despair. The effects of not having tests are not simply mechanistic. They are having real effects on real people at the end of their lives. People are actually losing hope. The effect of the drag, as it were, between testing and results, not only does it mean that staff are anxious and that places are understaffed, but it also means that there's greater reliance on agency workers and on ad hoc replacements. And the people who are ringing our helpline in utter despair and who we used to think we could help, we now can offer very little because the guidance is so rigid and unhelpful. There's no scrutiny, particularly of those places where there are serious concerns about standards, frankly. So it's not just people aren't being tested, what a pity. It's the impact on day-to-day life, on relationships, on staffing. And also, as Mark said, we don't live in a bubble here. We're hearing about 15-minute tests in Italy, in New York, in Germany, in France. And I don't know if any of you saw the Mail, but they did quite an interesting expose of how those tests were offered here and refused or just not responded to. And, you know, people have a certain tolerance, but 6 months plus on, people have died. People are now being allowed end-of-life visits, and the person they're visiting through a glass pane or in a freezing garden no longer know who they are.
Thank you. Andrew, please.
Hard to follow that. So to talk about hospitals again, so very different from care homes. So probably less than sort of 1 in 10 healthcare workers are regularly being tested if they're asymptomatic. So we're only talking about people who have symptoms and or who have household contacts who have symptoms. And the impact of that is that probably we know at the moment about 1 in 15 doctors are off sick, of which about half are due to either having a household contact or having symptoms and awaiting tests from COVID. So that sort of equates from the point of view of household members and awaiting tests about 1 in 35 doctors. So that's actually quite a big thing, because if you've got in a department of 10 people, you end up having 1 or sometimes 2 if you're unlucky, people off. You then have to get people covering shifts and doing ward rounds that they weren't expecting to do. And all of us have jobs that are generally pretty busy, and then to cover other work, it becomes a work. Now, we've managed that so far. And I think most people have stood up to that. It means that we're a bit more rushed about doing stuff. What I'm worried about is what's going to happen as things accelerate. And the last time I was talking to this committee, I was asked the question, did I expect a second wave? I said yes, and I think Mark said yes. I think we were in the minority at that point. Sadly, we were right. And we're now in a case where we're having to think about how do we deal when the numbers really crank up. And the likelihood is that those sickness rates and waiting for testing is become more and more a problem. And that's going to add pressure to the workforce. And that's as true in hospital setting as it is in the care sector.
Thank you very much.
Barbara Keeley.
Thanks, Chair. Well, I'll split the questions across the panel in a particular way, because it is slightly a different perspective that you are representing with us. So I'll start with you, Andrew, if I may. And if we can just amplify what you've just said, really, on the impact of the slow return of results or the lack of testing. What impact is that having now in terms of, I mean, what's the knock on, if you like, in terms of treatment, and where could that go once we've got not just the second wave, but winter flu, you know, impacting on that too? Where do you predict this is going?
Okay, so what we're saying at the moment is we're seeing sporadic cancellation of elective activity. So we'll always prioritise the emergency work. So if there is, you know, if I'm due to be in clinic today, but one of my colleagues is away, I will go and cover their on-call, because that is, you know, that's clearly the urgent stuff. But that then means that people won't be coming to clinic, or people are cancelling lists for procedures and things. So clearly that will have a knock-on effect on the patients who are expecting to see somebody or have a procedure. So that will happen more and more as sickness rates go up. At the peak in April, we were seeing large numbers of people off sick at any one time. So 1 in 5 doctors were off sick in the middle of the first peak. Now, we clearly hope we never get anywhere near that again. But even if we get nearish that has a big impact on the ability to deliver care. Now, because we had cancelled everything in the first wave, and we'd cancelled elective activity and everybody was ready, there was more cross cover. Our aim now is very different. We need and we must continue to keep the normal NHS services going for as long as possible. And so therefore, the impact of sickness is probably going to be greater because there's going to be less flexibility from the workforce in order to cover each other. And also this time around, we haven't got these. So last time we had 3,500 medical students acting up as FIY1s. They were fantastic, brilliant, lovely resource. Great time. We don't have them this year because the medical students are too early in their training, and plus they sort of didn't have much clinical training over the first wave. So I think the workforce is going to be really stretched as we go through winter. And winter, again, we're in a different time. In April, we were in spring, and the diseases and things that would normally come our way in spring are far less than what happens in winter. So that's why everybody's worried about winter. So we've got the potential triple whammy that we all go on about the normal winter pressures, plus flu, plus COVID.
Okay, thank you. And for Mark and Judy, Judy, you've touched on this in terms of visits, but what would be needed in terms of testing for visits to care homes, both, resuming those, because in some parts of the country they're not happening, and or carrying them on? You've talked about speed of tests, but do you have a feel for, either of you, what regime of testing would we need in place for care home visits to either continue where they are going ahead or to resume in all the parts of the country where they're not going ahead?
Well, I think one of the problems is that most visitors who are visiting care homes are either spouses or children or people very close to the residents. They're not likely, on the whole, to be mixing widely in the community. We're talking about people in care homes now in their 80s, 90s and 100s largely, often 80% with dementia, many with hearing and sight problems, for whom visits in, using technology or panels of glass or, sort of places in gardens are really not suitable, and gardens at this time of year and going on are going to be really problematic, particularly for people who are bedridden. I think that what we really want to see is a system that treats relatives or close people as caregivers in the same way as the Ontario Act, which has just gone through their Parliament, does, and ensure that the relatives can also help in a situation of shortage. There are people who help to bathe, help to feed, give reassurance. And we'd really like to know more, and perhaps your committee will help to establish this, about the facts of relatives bringing infection into homes, because all the research that's been done has shown that it's largely care workers who are obviously mixing with children, families, partners who work in the public sector and elsewhere. And it's a much more worrying cohort of people than relatives on the whole. We don't know if the guidance is based on hunch or good practice or research or what someone had for breakfast, because the idea that all visits in the guidance should be supervised is something else I'd like to get onto, actually. But the fact that
we're just testing for now.
Yeah, but relatives who have offered to pay for tests in some cases have still not been allowed to go into homes, and there have been some really serious implications of that, which are about residents' health, when they've got MRI appointments for cancers or serious medical conditions, and they've been told that if they go for those conditions for an outside appointment, they will be isolated in their rooms for 2 weeks. And the relatives are saying, no, we are not putting our relatives through that. we're taking the risk that they'll live with whatever it is.
Okay,
It's
thank
a
you.
serious business.
Thank you, Judy. It is, yeah. And Mark, anything to add? You said about earlier a 5 to 6 times increase in testing would be needed for family visits. Do you have anything to add to that? Or the quantity is the quantity and the turnaround, isn't it?
It is. I mean, first of all, you know, I totally and utterly sympathise with what Judy is saying. I mean, it is difficult for families, but it's also emotionally difficult for staff to be dealing with that separation of loved ones, and nobody would wish that on their worst enemy. The reality is that, you know, we're going to get an increase now of winter colds, winter flus. If the testing isn't coming back, then you're going to have to send everybody home who are symptomatic of a cold, unless you're absolutely clear that there's something that they've got that isn't consistent with a COVID diagnosis. So you're going to have to err on the side of caution on the staffing side, which is going to create shortages. It would be lovely to have the families coming in and supporting, but there's a 2 risk factor. There is that increased foot flow of about 6 times more people coming into the building, and whether or not it is more prevalent from staff or for families, the reality is the risk increases. But then the risk also increases because, as Judy said, most of the visitors are probably in the 60, 70, 80, 90 year age category. So there's also a risk to the people visiting if there's an outbreak in a care home or a potential outbreak where you've got asymptomatic staff members. The advice is confusing because we're being asked to say that if a family member does visit, they should be chaperoned and supported. And we don't have the model where the staff capacity is there to allow for that. So I think if we could crack the testing on, I mean, there was a project in Southampton for 90-minute testing, and I think Matt Hancock talked at one stage about it being available almost immediately, and then he kind of corrected himself and said, actually didn't mean to say that, it would only be used in labs to start with. But if there was a 90-minute test, I think some families would be very happy to drive to a care home, sit in the car park after having a test, and once the test results through, to then visit their family. And at least that element of risk would be taken out. But having had that announcement from the Secretary of State, we haven't heard anything since.
Thank you.
Thank you very much. Before I go to Caroline Lucas, just a quick friendly reminder, we've got just over 20 minutes left. So if everyone could keep questions and answers as short as possible, bearing in mind, of course, how important these questions and answers are, that would be wonderful. Caroline Lucas.
Thanks, Leila. I wanted to ask a question about the story that's been dominating the headlines for the last few days about these 16,000 positive tests that went missing. I mean, there's understandably and rightly been a real outcry about that, but I wanted to ask you more about what the impact of that will be in terms of the front line and in terms of care settings, just in practical terms. I don't know if Andrew Goddard, you might start on that.
We don't know. So we know that those 16,000 were all notified. So they would have gone into self-isolation. And we know that's probably the main key sort of factor when it comes to tracking and tracing. The contacts, and I think the Secretary of State is updating the House as we speak about where they're at with that, and understanding how many of those people are at risk of passing it on beyond, we don't know. And I think there really isn't any good data, and you need mathematical models like Professor John Edmonds, and I'm not one of those, to try and really have a reasonable idea of what the actual impact from the number of hospital admissions, say, is from a set number of people not being contacted through a contact trace system. It's hard to believe there isn't going to be any impact, and it's hard to believe there won't be any hospital admissions as a result, but saying how many, I think, is very, very difficult.
Okay, thank you. Mark, do you want to comment?
Thank you. I mean, like Andrew says, you know, without mathematical analysis, it's very hard to speculate on the impact. But I think for me, for a test and trace system to work, it's got to have public confidence. You've got many people who are very aware, very scared of the kind of Orwellian Big Brother, you know, personal tracing on your mobile phone. And we need to reassure and to give everybody confidence that this is something that everyone has a moral obligation to support. And when the state system can't get an Excel spreadsheet capacity right. It doesn't give confidence to people. And again, it then feeds into, you know, half of our 490 services are in areas of local lockdown. And if our people have been out in the community, you know, we don't have that extra form of protection if they have been in contact with someone. So, you know, we keep scoring these own goals, and it isn't helpful.
Thanks. And Judy, did you want to add anything on that?
Well, I don't really know, and I'm not qualified to comment on the lost cases, but what I would like to mention is the fact that, you know, when we don't have confidence in a system, as Mark said, it really makes it vitiates some of its impact. But the system we've got really discriminates against older people in the sense that you have to have a phone that's relatively new. And if we really want to protect older people, how many people have got a phone? I've got an iPhone 6E. I think I'm really trendy. But actually, most people I know of my age, I'm 82, don't. My husband, who inherited my old phone, can't, and who has had to be sheltered at some point, can't join the system. So really, I mean, one despairs, sorry.
Yeah, very good point that I think we're going to come back to in a second, but thank you very much.
We'll come back to the app in a moment, but first, Lord Mendelsohn. Thank you.
I just want to ask everyone a general question. In August, the previous session, there was some concern, need to improve the data flow that came from the commercial labs through the system. Just in review from where we were then to now, has this improved, or are there, you know, is all good, or are there other issues that have been thrown up as well, or if that one has indeed been solved? Andrew.
So I think we can't answer that question. Well, certainly I can't answer that question, but you have 3 people in your next session who should be able to.
Thank you. Mark or Judy, is there anything you'd like to add to that?
No, I agree with Andrew. I think that's a technical question really that needs to go to the next group.
Okay, thank you very much. And coming back to the app, Baroness Marsham.
Oh, I was wondering with our excellent panelists if they know anything about how the new app is working, because how are there enough staff to do the testing and the tracing, and how is it seen by the people who have the apps? Are they suspicious?
Yeah, well, I think Judy, you started some of that. I don't know if you want to start, and then we'll go around the houses. But what's your experience of the app?
Well, I haven't any. I mean, you know, I don't know anyone who's using it, who's able to access it, frankly. And it seems a bit bizarre to start a system that depends on you being, you know, up with the technology. Yeah, that's all I can say really about that.
Thank you. Mark?
Thank you. I mean, I'd probably actually agree with Judy that we've got 6,000 care worker team members, and I reckon that probably a good 10 or 20% of them are still using a kind of equivalent of an old Nokia phone. So when your own team can't actually download an app or be contacted, there's a risk. I think at the moment, you know, in the care environment, you've obviously got a situation where, you know, you don't fall under that kind of, I've been in close proximity to COVID if you're caring for somebody with COVID. But then if you get on the bus going home and somebody on the bus has got COVID, you could suddenly be told that you need to actually take precautions because you could have been exposed. So, you know, the guidance to care workers is a little bit confused. And at the moment, I think everybody is just looking at the actual rollout of the app as embryonic and far from proven.
Thank you very much. And Andrew, do you want to add anything there?
So my take on the app is that this is another weapon that we've got in the fight against coronavirus. It is not there to replace our sort of contact tracing system that we have set up for outbreaks. And, you know, I have the app on my phone. I turn it off when I go into the hospital because that's the right thing to do. And then I turn it off. But if there's an outbreak in the hospital, that will be investigated as per normal. And if I've been in contact with somebody there, then I will be contacted. So I am reassured that there are sort of ways to cover the whole of the system. But it does then cover me for when I'm on the bus, as Mark said, or when I'm on the train or in contact with people I don't know about. It's to catch those people that you don't know that you're with. And I think it's far from perfect. We all accept that. But it is yet another, if you like, weapon that we've got, and adding them all together. And it comes back, people are focusing on testing and tracing, and this session is focused on that. But social distancing and all the pharmacological interventions are really what is going to help keep COVID under control this winter. And if the app encourages people to think about that a bit more, that in itself would be a good thing.
Leila, could I ask you how many politicians are using it?
The app? Oh, I don't know. I'm not sure we can know through GDPR. We'll ask our colleagues in the tea room, shall we? Lord Strasburger. Oh, you're on mute, I'm afraid.
Thank you for that. Yes, I am using the app myself, having declined to use the previous version. Thank you, Chair, and thank you very much to the three panelists for giving us your time. Looking at the bigger picture on testing and tracing, how have we moved over the last couple of months? Are we in a better position now or a worse position over the whole test and trace service? Perhaps I'll start with you, Mark.
Thank you, Lord Strasburger. I think it would be wrong to say that there hasn't been some improvement. I think that keeping the economy going and supporting our children's education has undoubtedly put pressure on laboratory capacity. That notwithstanding, testing is better than it was, but it is a long way from where it needs to be. I would just remind, though, the committee that when we talk about these things, we're talking about the care home sector, which is something like 450,000 beds. In the supported living sector, where many people have exactly the same sort of vulnerability, many people at the same sort of age, there are 850,000 people that aren't yet eligible for testing. So, what we are desperately waiting for is our charity has 2/3 of our vulnerable people on the supported living side, and we haven't heard yet that there's any moves to start extending the testing to them. And that could be a major crisis if we have a big problem this winter.
Thank you. Judy, could we go to you, please?
I think that what Mark said about other client groups and other age groups is really important. And there are also the older people in the community, often living with complex health conditions, who aren't eligible for testing and who are suffering enormously from the lack of medical services. We know that, for example, there's a great dearth in care homes now, visits by chiropodists, by physios. What worries me also about when we're talking about testing is that a majority of care homes have not had COVID. We're hearing very little from them about what works and why they have been successful. When I've talked to the managers of some of those care homes, they are very frightened of putting their heads above the parapet because they're not necessarily obeying the guidance to the letter, which means that they are very frightened of insurance claims. We think that the DHSC ought to indemnify them, but also they're worried about being sanctioned or criticised or in other ways being affected by CQC if they're not abiding strictly by guidance. So it's a sort of perverse incentive. At the same time, we're hearing about hospitals now also, and local authorities paying extra to certain homes to make them take people from hospital back into care homes, paying much larger than normal sums per week, which seems a peculiarly perverse development when relatives can't come in and people from hospitals are being admitted. So it's a terribly confusing, I mean, Alice in Wonderland sounds more like a textbook to us at the moment rather than a fantasy.
It's an interesting point you've raised there. If there is a little bit of rule bending, which is actually improving outcomes, it might be interesting to know what those are. Can you give us any examples?
Well, yes. I mean, I can't obviously name the care home managers or those groups,
Oh, no.
but they have been meticulous in the way that they've trained their staff, kept in touch with relatives, protected visitors. But it has a cost. It has a cost, and particularly some of the not-for-profits that we're in touch with have invested, and some private companies too have invested hugely in the protection of their residents and relatives, and not all care homes either can or do that. At a time of crisis, when bed occupancy is dropping, when research shows that people are more frightened of going into a care home than getting cancer, the care home sector has had a very bad press, and it's seen as a place of death and also a place of isolation increasingly, which is why we just started our End Isolation in Care campaign, because care homes are there for people to end their lives in a good way, not in isolation.
Thank you. Andrew, would you care to give a view on how test and trace has improved or not?
I would agree with Mark. I think we are in a better place. Clearly, we've got an app now, which we didn't have. The number of tests we're doing far exceeds where we were a couple of months. But the demand is much greater, and that's the trouble, because we are now trying to test regularly asymptomatic people. It's great that that's all happening in the care homes. That's not really happening yet within hospitals. And if we need to keep people coming to hospital and being reassured that they can come to hospital and be safe, we do need to get testing for, keeping those COVID secure bits of the NHS working. So I think at the moment we're always going to struggle because the demand is going to be greater than the ability to deliver for testing. And hopefully, in 3 months' time or whatever, we will have enough tests, but the resource is stretched and there are still problems with getting hold of reagents. But the other thing to remember, and it was a great quote from somebody that I heard this morning, says that we can't test our way out of this crisis. Testing is a useful way for us to help control and mitigate the effect of COVID, but it is not the solution. And therefore, waiting to see what the vaccines bring us and what that means long-term for the crisis is probably the most important thing.
I hear what you say, but is the converse true, that without a very effective test and trace system, it's going to be very difficult to extricate ourselves from the situation?
Don't get me wrong. It is a really important part of the strategy, and it will mitigate and reduce that big peak that we've seen previously, and will keep it low, but it will keep it long as well. And as Judy said earlier, the public have to have confidence in it for it to work. You need people to use the app. You need people to be happy to be contacted and happy to self-isolate. So public confidence is everything.
Thank you very much.
Necessary but not sufficient. Baroness Finlay.
Thank you very much, and I apologise for coming into this a little late. My question is really for Mark Adams, and that is in terms of how much do you think at a local level the leadership in planning what is done has the care home sector and the domiciliary care sector around the table? Because I've been hearing concern from quite a lot of the care home sector that they just don't feel that they are at that central table planning locally as to how to manage, so that test and trace and so on are all things that are done to them, but they're not being consulted and don't feel they have a say in organisation. And different areas are very, very different. They've got different populations and different geography as well.
Thank you, Baroness Finlay. This is a very, very sensitive and complex area, because certainly regionally public health has been decimated with cutbacks over the years, so they weren't prepared or geared up to handle a crisis like this. The way in which the system works is peculiar and complicated. I mean, I sit as a NED on an acute trust board, and watching both sides of the sector with kind of equal frustration and confusion, because the system doesn't work in a fully joined up way. As one of the largest social care charities, we haven't been sort of requested locally to sit down in any part of the UK and give our contribution or experience. I sit on the board of the National Care Forum. They are more involved nationally. But again, I think that the future of health and social care really does need to be delivered locally with much greater forms of joined up cooperation, because we're just missing so many tricks. We could have done this an awful lot better, including, I think, just using university laboratories, private laboratories, and setting the local authorities with the task of making sure they had the capacity to meet their needs. And trying to run a model like that nationally is always going to be difficult.
Yeah, thank you. And very
thank you.
We're going to be picking up on in the next session, I'm sure. So we've done incredibly well. And I've one final question left to ask you all. And you've got a maximum of a minute, so in just a minute. But if I was a coronavirus fairy godmother and could grant you just one wish, one thing for government to do as soon as possible, from your perspective, what would it be? And I'll go to Andrew, then Judy, then Mark.
For testing, it would be to have testing within 24 hours for all health and social care and care workers.
Thank you very much. Judy?
Certainly to include relatives as caregivers. And secondly, to give CQC inspectors the right to be tested so that not everyone has a relative and we need scrutiny.
Thank you. Mark?
If I can be really greedy and sort of squeeze two in,
of course you can.
I think that 90-minute testing, if that could be proven and scaled, that would solve an awful lot of issues with regards to families and loneliness and all the issues we've been talking about. And then I would just flag up that the 546 million increase in the infection fund won't get us through this winter and is going to cause some severe problems fairly quickly. So if the fairy godmother could look at that as well.
How much money would you like the fairy godmother to give you?
Well, I mean, obviously, at the start of the crisis, we had a total of something like 3.8 billion passed through local authorities in various guises, and that was for a shorter period to less people. I don't think it necessarily needs to be to that magnitude, but I would be thinking that you'd be looking at least 2 or 3 times the initial commitment.
Which is significant. Well, thank you, all three of you. A very sobering 45 minutes, I think, for us all, but wonderful to have you back. Really appreciate it. Thank you for your thoughts and your suggested recommendations. As ever, we will take those on board, include it in our reports, write to various departments and continue to press on your behalf. Thank you for your continued engagement. We really, really appreciate your time. So Mark Adams, Judy Downing and Andrew Goddard, thank you so much for being with us this morning. And I see already that Alan Wilson and indeed Rachel Liebman is on the call. So we can segue neatly to the next session. And of course, all three of you, you are very welcome to stay, but I know you're incredibly busy people and we shan't be offended if you go off and do something else. So by all means, stay. So thank you so much, all of you, for joining now the second half of this session. We are focusing, as I said at the beginning, on test, trace and isolate, a very apt time to do so given the news. But what we are going to now move to is the organisation of test and trace, and hopefully be able to dig down a little bit into this issue with some real experts in this. So I welcome Dr. Rachel Liebman, who's the Vice President of Communications and International at the Royal College of Pathologists, and also is Group Medical Director of the Doctors Laboratory and Health Services Laboratories. So wonderful title there, but clearly full of experience and I'm sure lots of knowledge that we will draw on. And also welcome to Alan Wilson, who is the president of the Institute of Biomedical Sciences. So it sounds very much like you are very much in the thick of it. So I'll start by asking a very general question, perhaps to Alan first and then to Rachel, if I may. What are the key issues in regarding to testing at the moment, and has the situation from your eyes improved as the pandemic has progressed? Alan Wilson.
Thank you, and thank you for inviting me to present evidence to this hearing. I think the main emotion at the moment felt within the laboratories is probably frustration. I think I'll answer your second question first, in that I think, generally speaking, it has improved. The Pillar 1 labs have worked very hard in the background to build capacity across all the NHS labs and the private partnership labs, and that capacity is slowly grown over the last 6 months. But as we've heard in the previous session, on occasion, that's been really stretched by an increase in demand. I think what the frustration comes down to, we think within the Pillar 1 labs that we could make this work better, and we have a variety of suggestions where we could make this work better. And I think one of our main limitations is that we have this separation of the two testing streams between Pillar 1 and Pillar 2 that we view as unnatural, foreign to lab testing, diagnostic testing within the UK, and also the secrecy of which Pillar 2 operates under makes it very difficult for us to find out what the issues are. So we are asked questions about capacity, about turnaround times, and we can answer that for the Pillar 1 laboratories, but struggle to get information about Pillar 2. And Pillar 2 labs are still the labs that are doing the majority of the testing for the test and trace strategies. So the issues that it's clear there are issues, as we've already demonstrated, around about turnaround time, but we're not quite sure what that means, and we're not quite sure what the capacity issues are. The other thing I think that's still key, we're still holding capacity issues due to intermittent problems in the supply chain. And that rises every now and again. We have certainly, as I said, worked very hard within Pillar 1 labs to maximise our capacity, and we've done that largely through innovation, through ingenuity, by taking on different testing platforms, by spreading the load across different testing platforms to make us more resilient. And at this stage, I would like to pay tribute to the people in Pillar 1 labs particularly, who've done this work over the 6-7 months since the pandemic started. And I sit regularly on the Scottish network meetings, but I know meetings regularly take place within the English pathology networks, and we work very collaboratively together. We share expertise, we share reagents, we share chemicals, we share capacity for testing to try and ensure that that testing is delivered where it's needed most. And I think that we are now facing significantly challenges with that, though, because we had the capacity at the beginning of this pandemic due to a decline in workload from GPs and from outpatient clinics. That capacity is now being slowly eroded simply because we're now returning to business as usual. So the swabs and the bloods and the urines that come in from GP practices are now returning to their usual numbers. So we're now having to do COVID testing, which obviously did not exist pre-COVID, plus business as usual, and also now being asked to take on some samples that were previously destined for the Lighthouse labs due to capacity issues within the Lighthouse labs. So I think the overall feeling, I think, is around about frustration. We think this could be run better, and I'm sure we'll get onto that later. But at the moment, we see real issues and a frustration that we are not being asked to help.
Yeah, thank you very much for that, Pawsey. And if we don't come back to the specific points that you want to raise in terms of how we can do this better, please do crowbar those in, because I think that's vitally important. But Dr. Rachel Liebman, do you want to give your overview right now? How are we doing? I'm afraid you're on mute.
You're on mute, Rachel.
The classic problem. So I don't want to repeat what Alan has said, but I would echo what he has said so far and point out one area where we definitely have improved. And just for your information, Alan mentioned supply chain issues, and we now have central procurement for a great deal of the equipment and the reagents. That was it was a blunt instrument, but a very necessary instrument during the first wave. And that system is now working much better than it was. We've got a series of networks which are closely aligned to help distribute those pieces of equipment and that reagent supply to maintain our ability to keep up the testing in Pillar 1. And it also there's national procurement, which keeps Pillar 2 supplied as well. So I thought it was important that you know that that's working well. And also, I think we need to pay tribute to two people who have been keeping that going with almost interminable calls and no rest. And that is David Wells and Angela Douglas, whose contribution to that national supply chain has been phenomenal. So I just want to pay tribute to them.
Well, thank you for that. And I think we can all echo the tributes to everyone who has been managing this crisis. And thank you, Alan, for raising those. Alan, I just wanted to ask a quick follow-up. It's also based on the evidence that we've seen prior to the session beginning about the idea of competition between Pillar 1 and Pillar 2 labs. I was wondering if you could expand a little bit on where that competition is coming from and how you see us being able to solve that, because it strikes me as being bizarre that we've got labs competing in this way in a system that's meant to be working all together to keep us all safe. I was wondering if you could expand on that.
There's two potential issues here. I think one of them is largely being solved, and certainly at the beginning of the pandemic, we were all searching for, when there was a real scramble around for trying to source equipment and consumables to do the testing, and we were certainly in competition there, particularly for those reagents and chemicals that are core to any test that we do. For example, some of the transport mediums and some of the swabs that we were all struggling to get. And I think setting this high number of tests, I think, forced labs to stockpile some of these chemicals and consumables that we need that were critical to the testing pathway. And therefore we ended up with stock in some places sitting on shelves and other places in the country where there was desperate shortage of chemicals and some of the reagents. I think that's largely been solved now, simply because the supply chains are slightly more secure and there's more in the market. So those pockets of problems have been largely ironed out, although they still surface intermittently as we have intermittent interruptions to the supply chain. I think the other issue that we're facing at the moment, though, is slightly more interesting, is that I think we're now in competition for staff. Mm-hmm. And I think that's something that's now emerging and is going to become an issue, more of an issue, as the more of these, the lighthouse labs emerge. And it's interesting to note that 2 have passed their forecast opening dates without any operational activity as far as we can see. I think now, it's certainly within the NHS and other Pillar 1 labs, we're all been asked to give plans for the future delivery of COVID testing. So we're all recruiting, we're all looking for staff to deliver this testing over the next year to 2 years. And also now the Lighthouse Labs and Pillar 2 are doing the same. So I'm now actually competing for a relatively small group of expert staff, biomedical scientists, clinical scientists, and other expert staff. And I think that's going to be a real issue. And I do think that's a potential factor in the fact that these Lighthouse Labs have now not opened on their due date, is simply because I think they're struggling to find staff because we're competing for that. We're all fishing in the same relatively small pool of expert individuals.
Thank you very much. Very interesting. Rachel, do you want to add anything there?
No, except to say that I think that a much closer working relationship between Pillar 1 and Pillar 2 would benefit everyone.
Yes.
I think there's a great deal that Pillar 1 could learn from Pillar 2 and vice versa. And there is, to my mind, no good reason why we don't have mutually beneficial relationships. So the college would like to see a relationship between every new lab that's being set up and an existing diagnostic laboratory, public or private. But those existing diagnostic laboratories have already solved all the problems that the new labs are just encountering for the first time. We've been doing this for years and doing it well. And with all of the IT and logistical support that you need, we know what the answers are. So I think that's really key to making sure that we have the kind of capacity that we need.
Yeah. I could really like to echo that. I think it's a frustration right from the beginning of this pandemic that we view ourselves as the experts in this area. And that's what we have. The scientists working in Pillar 1 labs have been doing this for decades, running diagnostic labs, connecting the whole specimen pathway from when the sample was taken to the final report goes out. So we have decades of experience within our memberships of connecting, of IT, connecting systems, because that's what we do. It's bread and butter to biomedical scientists and others who work in the Pillar 1 labs. And largely we were bypassed at the beginning of this. And it's interesting to look at how we set up the Nightingale hospitals as an extension of the existing NHS with using NHS staff. Whereas when we looked at testing, we set up a parallel but unconnected model testing stream from NHS laboratories. And that expertise that exists in Pillar 1 labs was largely bypassed. And I think there's a real frustration. And I think there's an element of that. That's the frustration word coming out again. We think we could have done this better, and a different model would have existed if we'd been involved in this decision-making process at the beginning. And I fully agree with Rich. I think Pillar 1 should be controlling Pillar 2. We should be looking at that. We should be working together to produce one flexible testing pathway where we could move work around where there are pockets of problems, and we can work together to solve the issues that we're currently seeing coming out.
Thank you so much. Barbara Keeley.
Thank you. And we've reminded ourselves this morning that Pillar 1, for those who join us, is swab testing in Public Health England labs for those with clinical need and health and care workers. I should say that I think that does include the new saliva testing, because I'm an MP in Salford where we're starting to work on that. And Pillar 2, obviously, swab testing for the wider population processed in the Lighthouse labs. Obviously, there is a need to test widely, and we're very interested in getting into this organisation question with you. So I guess my question is, can the current system of Pillar 1 and Pillar 2 be used to achieve that goal of testing much more widely, because the demand is driving up and up and up? And I guess there's a secondary question, really. Will our current test and trace systems cope with the pressure of winter? And if they're not, I mean, do you want to enlarge on what needs to change that you've already started on, really, in terms of talking about cooperation or the pillars working together in ways that they're not at the moment? So can they just be a system used as it is at the moment to test more widely? And can it cope with winter? If not, what needs to change?
So can I start with that? Yes. So I think I would firstly gently challenge the assumption that we need more wider testing. I think that we need testing that is for a purpose. Testing has to be of specific individuals. So they either need to be individuals who have symptoms or who are the contacts of those who have proven to have COVID-19, or they are people who are being tested in order for a function to be carried out. And that might be healthcare workers, health and social care workers, key workers. But what it isn't is just any member of the public who wants a test being able to access a test. If you've got no reason to access a test and we have capacity issues, then I would argue that we're not really using it properly. So that's the first thing to say, is I just think an assumption that it needs to be everybody is not, in my view, correct. It needs to be in the right context. And I'm not sure we've got that at the moment. But certainly we do need as much capacity as we can get for those focused activities. So there's certain activities where we already provide testing and they should remain. And for symptomatic patients who have been referred to a sampling centre by their GP, to be turned away because all of that capacity has been used up by people who may not have any symptoms at all, is completely inappropriate. And it doesn't fit with healthcare. If we're here to provide for people's health, that's not appropriate. Someone with symptoms referred by their GP should take priority. And that's something we're used to in the NHS. We do prioritization all the time. And I think we should be prioritizing testing. I don't think we need to go back to the draconian situation that we had during the first wave, when testing was very much more limited, where you could only get a test if you had severe symptoms and were being admitted to hospital with severe symptoms. Our capacity issues are not back there again, but we do need to have a strategy that tests for a purpose. And currently we don't appear to have one of those. So we've already touched on the improved collaboration. I think quite clearly you need a combined management structure between a Pillar 2 laboratory and a Pillar 1 laboratory, or a network of laboratories, in order to make sure that several things happen. Firstly, you break down those competitive barriers which Alan has so eloquently talked about before. You also make sure that you've got the best use of resources, and that's intellectual resource as well as physical resources, reagents, consumables, and equipment. Obviously, your staff rotas then become easier to provide on a 24/7 basis if you know what you've got across a wider field of people. But one of the important things is on that secrecy. And that secrecy and mistrust, I know we're going to probably touch on that later, but it's a major problem. It is a major problem, and it really doesn't help for those of us who represent experts in the field, like Alan and myself, to have to say to the people in our organizations, well, I don't know. And one of the things that we've noticed is that we recognize the outcome of decisions, and then we, as the College and the Institute of Biomedical Science, have to retrofit what we think the decisions were that led to those outcomes. That shouldn't be the case. So in all of the committees that are set up to run test and trace, testing system, and each of the pillars, in all of those committees, given that test is one half of test and trace, you should be able to see pathologists and people who work in pathology laboratories represented almost 50% on each of those committees. It's absolutely not the case. It's a real struggle to find anybody with testing experience and knowledge involved in the decision making. But that collaboration, and I mean really quite close collaboration, I don't mean the occasional trip down the road to see each other's laboratories. Pleasant though that is, that's not good enough. What we need is real working together and combined management and leadership structures to make sure that we make the very best use of what capacity we've got. So sorry, that was a little long-winded, but I think it was important.
No, I let you continue because it was clearly very, very important. Alan Wilson?
No, I've not much to add to that. I think that was a very eloquent description of where we need to be. As I've said, I think it's summed up that I think Pillar 1 needs to direct Pillar 2. I think we have that expertise, and that's what should have happened from the outset of this, and that's now what we should try and do. And it's slightly frustrating to see new lighthouse labs emerging, still not listening to that professional advice about how these laboratories should run. With meaning absolutely no disrespect to those who run the Pillar 2 labs. The people working in the Pillar 2 labs and the Lighthouse labs do not have decades of experience and breadth of experience that we have within the membership of the college and the institute to help with that. They are academics who run research labs. That is not the same as running a busy diagnostic lab. And I think that's been more clearly highlighted in the IT issues that we've seen recently and over the last 6 months, because we've got that experience of connecting systems, because that's what we do.
Thank you very much.
Thank you both. Can I just ask a quick question to Rachel? Because very good answer on organisational changes needed. On testing more widely, we did hear that to allow care home visits safely, it would take 5 to 6 times increase in the amount of testing in care homes. Would you include that in your schedule of who needs to be tested?
So definitely in terms of key workers and key carers, yes, they would certainly be included. There is, to my mind, there was in the first wave too much of a focus on primary care and too little of a focus on secondary care. And again, in diagnostic pathology, we provide services across both of those sectors, as well as to the general public in terms of screening programs. And we do that very well and at a very large scale. So we're used to doing that, but that's not quite the same as just anybody who wants a test getting access to a test.
No, it isn't. Thank you.
Thank you so much. Lord Strasburger.
Thank you, Chair, and thank you to both our panelists. I want to ask a question about something that has fallen out of public discussion recently, which is the accuracy of these tests. Could you give us the up-to-date position on how accurate these tests are? If I get a positive or a negative test, how likely is it to be correct? And are you also able to cover antibody tests while you answer the question? Rachel, would you like to go first?
Okay, so I'm happy to go first. I wish, Lord Strasburger, that I could say that there was a perfect pathology test anywhere. Unfortunately, that does not exist. What we have are pathology tests which are extremely accurate, but there are always going to be exceptions to the rule because pathology works in a biological circumstance. The staff aren't robots, the equipment is not the same in every single laboratory, nor the structure, nor even some things that we test for can be affected by temperature changes. And you know how much that changes during our annual cycle in the UK. So all of these tests have got some false positives and some false negatives. But the most accurate is the throat and nasal swab PCR test. That is the gold standard for deciding whether or not someone has COVID-19. Even that has limitations. If you take the swab too early, the patient may already have the infection, but not have enough virus on board that it shows up on the PCR test. And the restrictions or the limitations of that test at the end of an infection are that sometimes it's so sensitive that it will pick up residual viral particles after the person is well and can get back to work. So as we've learnt more about COVID-19, we've learnt how to deal with those issues. And there is a sweet spot as to when it's appropriate to get a test. And that was shown to be quite a problem when we had difficulties with people being able to book tests, in that the sweet spot was passed before they were able to access that. And that's a problem. So definitely when you are symptomatic, or if you've been told you're a contact, or there are other good reasons because of your work that you need to access a test, it needs to be relatively quickly, but within that sweet spot of when is the right time to test.
Can you put any approximate percentages on that?
I wouldn't like to, because each individual assay varies and the assays vary in each laboratory. So I mentioned earlier that there's been a move to centralized procurement. There's also been a move towards centralized, if you like, verification of tests. And I would caution against an idea that there's only one group of experts in the country who can decide whether or not a test is useful. For the reasons I've mentioned, firstly, there's not just one group of experts in the country. That's the first thing to say. And the second thing to say is that
she's on tenterhooks with the second thing. I hope perhaps.
Shall I move over to Alan for the time being?
Let's go back to, yes, indeed. So Alan, do you want to answer that question? Then we'll come back to Rachel when her line improves, hopefully.
I think, is that her back on now? Is that?
Oh, are you back, Rachel?
Rachel, you back, Rachel? We lost you there, Rachel.
Sorry, I do apologise. I haven't done anything to affect it. So the thing was around expertise in deciding which tests could work and which ones can't work, and what the accuracy of the tests are. So I think it's a mistake to say that there's only one group of experts in the country who can decide that. That is not how pathology tests are rolled out. Each individual laboratory has to, as an accreditation requirement, assess an individual test for its own use. And they will get a slightly different set of percentages, Lord Strasburger, than the previous central testing laboratory. So it makes sense for the country to invest in things which have been proven centrally. I mean, it does not make sense to invest millions of pounds in untried and unproven technology. But then as those technologies are rolled out, the percentages of sensitivity and specificity are not static. They will slightly change depending on which laboratory they're used, because that's one of the things that expertise does, it tweaks. So if I were to give everyone on this panel a recipe and say, now I want you to be an APPG bake-off, you'd all come up with a different result. And that's because despite the fact that the recipe is written down, it turns out differently in different kitchens, in different ovens. And so you have to actually take that into account with laboratory practice as well.
Yeah, I think we've got that message. Thank you. Alan.
Yes, I agree. I think the choice of test is vital. The PCR is undoubtedly the gold standard, and that's what we're using across the country. I think the other thing worth mentioning is the performance of this test will also vary depending on the prevalence of the disease. And I think that's not clearly understood in some areas as well. especially we had interesting issues when we had a very low prevalence. That seems like a distant memory now, unfortunately, but when we had a low prevalence of this disease, then the test sometimes was producing effectively false positive results more often, because it's, as Rachel has described, it's not a perfect test, but it's the best we have at the moment. And within the constraints that we have, it's the one we should be continuing to use. I would caution against some of the headline-grabbing headlines that we see about new tests and what they're able to do and how quickly you're able to do them. They're very easy to write, very difficult to evidence. And I think some of these have absolutely no place within the NHS or within the UK. Others are certainly worth a further investigation, and we will certainly do that. And we will try and verify these and see where they fit. But I think it's very frustrating sometimes, we said, when we somehow seem to be resistant to tests that take half an hour and can be the answer to everyone's prayers. They're often not. If the story is too good to be true, it's often because it's not true. And I think we have to be careful about looking at these and running with these stories and putting political pressure on the laboratories to do that we have seen. And we have to be cautious and maybe listen carefully and observe carefully the evidence base for this, and not run in the wrong direction, as sometimes we're having pressure to do. As to antibodies tests, sorry. Yeah. As to antibody tests, I think we've been doing antibody tests for some time now. They are probably of very little routine use in the fight against this virus at the moment, simply because we don't know what the answers tell us. People who have antibodies may very well have antibodies to this virus, but that does not infer immunity. And I think that's the issue here. And I think the challenge sometimes is that if people prove positive for the antibodies, they somehow think they have donned the bulletproof vest and can go out and have challenging behaviours simply because they have immunity. Whereas at the moment, we do not know what that antibody test gives us. And actually, the early evidence suggests that immunity may only last a matter of months.
Okay, thank you very much.
Philippa Whitford.
Thanks. If I could start just a short follow-up with Rachel and then Alan. Obviously, the original advice was to try and get tested as quickly as possible after developing symptoms, preferably within 3 days and an absolute within 5 days. But on Friday, the government has extended that, just saying, get tested within 8 days. And I can't find any real change in evidence. And I've seen public health people criticizing that. It is still the old advice in Scotland. So Rachel, are you aware, has that been changed because of a genuine reason or to manage demand? And is it not just going to delay when people get a result and get contact traced?
So I'm not aware of, like yourself, of any change to the evidence on which the guidelines for testing timescales has been based. So I suspect that this is a pragmatic decision based on demand and supply.
And yourself, Alan?
Yes, I would agree. I have not seen any evidence, and it's interesting, in Scotland where I work, we maintained that previous guidance. And I suspect it is, as Rachel suggested, a pragmatism around about turnaround times in supply and demand.
I mean, the problem is, as people become infectious about 2 days before they become symptomatic, if they're only tested on day 8 and only get the result day 10 or 11, their contact's been out and about for 2 weeks. I mean, I can't see the sense in it. Thanks very much to you both.
Excellent. Caroline Lucas.
Thank you, Chair. I wanted to ask a question really a little bit about the kind of the resilience of the laboratory capacity, and in particular this question that you've touched on a couple of times between centralisation and decentralisation. I think during the course of having listened to you, maybe my question about whether or not we needed more decentralised labs has been overtaken by what you've said. But I just remember very early in the pandemic, there was a lot of discussion about universities having capacity for testing, but they were being bypassed because there was a real push to have centralised tests. So I guess my question is there unused testing capacity that will be useful to bring back online? And if that's not necessarily just in terms of increasing the total number of of tests being done, would it actually strengthen the resilience of the whole system, so it's less likely to topple over when things go wrong?
Yes, I think it probably, I think we would like to see testing moved more locally in general. I think the centralised testing model delivered through the Pillar 2 and Lighthouse Labs, I think has well demonstrated flaws. And I think moving the testing into a more local environment would improve turnaround time, it would improve response rate as well. And I think it would improve, it would potentially reduce transmissions of this virus. So I think we should look to use testing as local as we can within these areas, and link it, as Rachel has suggested, to NHS laboratories or Pillar 1 laboratories, and I think that would help markedly.
Without putting too much pressure on those Pillar 1 labs, though, would we need more lab capacity locally to make that work?
Yes, I think we would, and we are building that at the moment. Somewhere within the Pillar 1 labs, we have a capacity somewhere around the region of about 60,000 tests per day. We see that rising quite steadily until close to 100,000 by the end of October, and that would build the capacity to deliver most of that testing locally. But again, if we had this control over between this collaboration between Pillar 1 and Pillar 2, we would be able to move work between the two sectors very readily, so that one was overwhelmed, we could send to the other, and vice versa. And I think that's what we're looking for. Both Rachel and I have highlighted is that we need this collaboration, open relationship. And effective, I think the first step of this is simply to have a round the table meeting between representatives in both Pillar 1 and Pillar 2 and look at our problems and see how we can help each other. We're not suggesting that Pillar 1 is somehow that has all the knowledge. What Pillar 2 done should not be overlooked. They have met a huge capacity in a very short space of time, and they need to be congratulated for doing that. And it's been an incredible effort. And we can learn from that as well. They have industrialised a test to a scale that's probably foreign to most NHS and Pillar 1 labs. So we're keen to learn how they did that, as I'm sure we're keen to offer then our expertise to the Pillar 2 labs. But keeping it local, if we control it locally, then we can flex between Pillar 1 and Pillar 2.
Thanks.
So if I can follow up on that, the first wave saw research activity come to a real screeching halt in the UK and elsewhere because of the pandemic. So researchers who would normally be working in academic laboratories in universities were sent home. So of course there was capacity. But as we all know, with very interesting results, the universities are back in business. So they're back in business, both teaching and doing research, non-COVID related research. And so that level of capacity is no longer there.
Yeah.
Okay, thank you very much. There was a quick follow-up question I'd like to ask now about, do we have any evidence of sort of quality control issues being a problem in Pillar 2 labs? Alan, I wondered if you'd wish to comment on that. Is there any reason to suspect that the quality of testing in those labs is not as high as in Pillar 1? Or is it more organisational issues that you're referring to that need to be learned from?
It's not much, but my issue is it's secrecy. It's very difficult to find out what is happening in those labs to make actually an informed opinion on what quality issues there are. So that's been my first point. Second, I think there were some quality issues at the beginning of this, and that's maybe not surprising given what they were trying to do at such a pace. But more recently, I think that the results coming out give some confidence that that what they're doing in the test kits they're using, that they are less. I think they've reduced those quality issues, but as I say, there's very little evidence to actually be sure about that. I think what we would push for is that what the laboratories lack is state HCPC registered biomedical scientific staff to run those laboratories, and there seems to be precious few of them within those laboratories, and we need to see them moving to accreditation as well. But then NHS labs are still moving to accreditation, so they're not unique in that as well. But I would say there's no overwhelming evidence at the moment to say that there's a quality issues with what's coming out. There's been some well publicised problems around about one particular lab in there, but again, I think my perception of those issues are being addressed.
Thank you very much. Lord Russell.
Yes, Alan, I'll start off directing this to you because you did touch on it earlier. The much publicised the incorrect accounting for tests, which has recently caused a degree of embarrassment. for the government. I think you alluded earlier to the fact that you felt this was, in a sense, an accident waiting to happen. And if this had been set up properly in the first place, it would never have happened. Could you just expand on that and say what you think needs to be done to make sure it doesn't recur?
I think we need to lean on the experience of the labs who have experience of doing this, of building IT and connectivity between systems. Certainly, it is pretty foreign to find within NHS labs at the moment using spreadsheets to transfer data. That's not something that we would do. If we are integrating systems, we integrate them by direct interfaces between the testing platforms and our laboratory information system. And that interface is designed over time and tested to make sure that the appropriate data items are going to not only into the information system, but then being passed on to those who need to act on them. So I think that's what we need to do. We need to use systems like that rather than using spreadsheets to transfer information. That's something that I wouldn't say it was foreign when you use spreadsheets, but certainly not in this way. We don't use that to transfer information between IT systems within the NHS, generally speaking. And I think that I would have hoped that if we'd been involved in this from the beginning and we'd looked for the pathology community expertise, we would have not developed a system along those lines. It's something that we maybe use at the very beginning of a system, but very quickly we would move to a fully integrated, what we call an interface, where the results pass seamlessly from one system to the other, and then they're available almost instantaneously to the clinicians that respond, that they requested them.
Rachel, do you have any further comment?
No, I totally agree with Alan, and I know that the college position is that we want electronic communication as much as possible, and that does not involve Excel.
And would it be fair to say if what you strongly suggested was the much tighter coordination between Tier 1 and Tier 2, if that actually happened, this would be an issue which would be sorted as part of that cooperation?
Yes.
We would hope so, yes.
Thank you very much. Lord Mendelsohn. Who is on mute, I'm afraid.
My apologies. I just wanted to cover a couple of questions. One's a more general one, and one's very specific to the recent times. One is just if you could give some observations on the correlation between the number of tests and the number of people tested, and how that has changed over time, and also one of the issues that we have about defining capacity versus the number of tests versus the number of people, because we have a capacity figure of 2.6 million, and it doesn't seem to be clear how we arrived at that and what that relation is to the testing one. So just some observations about how those numbers stack up and how we should see them and interpret them. And then something more specific about these positive tests, the 15,893 tests that were found to be positive and not in the Excel spreadsheet. What impact do you think that has on public confidence in the testing regime? And what's the easiest and best way to be able to get that back and to be able to encourage people to have full confidence that the testing regime will satisfy their requirements and the country's requirements?
I can pick up the capacity issue. I think it's a very difficult one. You can measure capacity within laboratories in many different ways. It depends how you ask the question, and you need to have the knowledge to then go in the follow-up as to what you mean by that. Capacity can be measured by, if you buy a piece of a testing platform, they will quote your capacity of X thousand tests per day. But that's obviously dependent on you having the staff to run it, having the consumables to put on that, to do that, and having the connectivity around it to generate those results. So I think we've been asking sometimes the wrong question, or maybe just listening to the answer that if we like the answer, that was fine, without drilling down and actually asking the difficult questions about what you mean by that. And is that real-time capacity? Is that something that's theoretical and dependent on other steps being in place before you can realize that capacity? And I just am cautious that the capacity figures we've been quoting have been flawed, simply not because we've not been asking the right questions, or we've liked the answer we've got and we said, yes, that sounds a nice big number, so we'll run with that without actually asking what that means and can we deliver that capacity on the day. Because the first time that capacity was tested, we failed and we did not meet that. So there's an issue here around about definition of capacity, and I think we have to be very tight, especially when we're now talking of bringing on new lighthouse labs and what that capacity brings. We need to be very clear exactly what that means, and they are fully operational, staffed, have the supply chain to deliver the numbers that we talk about.
So I would agree with that. I would add as well, it needs to be additional capacity because of additional supplies. If you take a centralized procurement and you just spread it more thinly, you haven't increased your national capacity at all. And I'm afraid I can't answer the question as to what exactly is our capacity compared to the number of tests. And that's partly down to that secrecy element that Alan was talking about. The transparency isn't there for us to be able to make those judgments. I wish it were, and it should be. We should know what our national capacity is, especially since we have national procurement for some aspects of it. But capacity comes down to equipment, reagents. And I'm sad to say that some of the equipment manufacturers sold the UK large volume pieces of equipment and then didn't follow up with enough reagents to be able to work those. And so our potential capacity was very constrained by that. It's also things like consumables. So at the moment, some of the assays have got a problem with pipette tips, which are the little plastic bits that go on the end of the pipette to allow you to move samples from one test tube, if you like, to another. And if you don't get exactly the right ones of those, your capacity is impacted, and they are specific to the assay. It's obviously greatly around people and how you use your people, those rotas. So are they voluntary staff who will go back to the day job? Are they permanent staff? Are they part-time, full-time? Is it possible to move to a 24/7 rota with those people, or will that simply stretch them too thinly? So again, we need actually to understand all of that. And it's also around space. So a lot of these samples are coming in postal sacks. And if you can just imagine how many postal sacks we're talking about when we're talking about, for example, 7,000 that my laboratory does on a daily basis. Just imagine how many postal sacks that is, and the people needed to unpack them and to log those onto a computer system. It's a huge logistical issue, but it impacts on capacity. So we also have to see capacity in terms of what I mentioned earlier on, which is managed demand. We simply do not have and never will have the capacity for everybody who wants a test to simply get a test. We need to manage that, and we need to manage with very clear messaging who should be attending for a test, how often and where, and how do they book it.
Thank you so much.
Leila, could I just very quickly,
very quickly,
it's a very quick answer. So we can't have confidence in the capacity number. Should we have confidence in the test number, the people number, or only the number that we know we didn't of people who were not put on the system?
I think we can have reasonable confidence in the test number, certainly from Pillar 1. And even I think largely from Pillar 2, the test numbers, generally speaking, I think are now accurate in what we're doing, that utilisation. But certainly the capacity, I think, is still a little bit dubious.
Right, thank you. Baroness Masham.
What do Rachel and Alan think of the new app on telephones? Is there enough people to trace, and is there enough capacity in the labs? And how do you think it's going to work out?
Alan first.
I think it's certainly a step forward, the new app. Certainly there's some frustrations around about it, about the technology required and the fact that they don't work between Scotland and England, which is slightly odd. But certainly I think it should detect outbreaks. It should allow us to control those outbreaks. And more people that download the app, then we would hope we would have that capacity locally to deal with those outbreaks. So yes, I see the app as a positive step forward, providing this, but it does need adoption. We do need that widespread adoption of that app to then hopefully we can then do the contact tracing and the isolating.
Thank you. Rachel?
So I would agree. I would say that the use of technology, and in particular mobile phone apps, makes a great deal of sense because it's something that quite a few of us never leave the house without now. And I know that there have been some really successful passporting systems using mobile phones that directly connect back to the laboratory that's done the testing. And an example of that is in Premier League testing, where there is a passport that says you're safe to come into this sporting arena because you've had a negative test within the last X number of hours, and that is electronically linked immediately to a mobile phone app. So there's some really good examples out there of how this can work. I have one slight reservation on a population-wide basis. This is in addition to Alan's reservation around the devolved administrations having different apps and different jurisdictions. My reservation is, I wonder, does it increase that inequality of access? Because we already have an inequality of access in that those who can drive to a swabbing centre are more likely to be able to access a test. And we know that 40% of care home workers do not have a car. And if you then say that only the technologically able and adept and those with smartphones have access to the app and therefore have access to this, I have concerns about that as a doctor about what that means for our communities, because I don't feel that an inappropriately skewed access to testing helps us in any way with an infection that we know specifically seems to be targeting those who are in at-risk groups and who are in at-risk occupations.
Thank you very much. We are in borrowed time, but a very interesting final question. Philippa Whitford.
Thanks very much, Leila. If I could start with you, Alan. The Lighthouse Lab in Glasgow recognised quite early that postgraduate students would go back to uni and put in things like automation and standardisation quite early on. Is that going forward in the other Lighthouse Labs? And are they standardising the packaging? Because what Rachel described about the sacks of post, I read that literally all the packages and swabs and tubes can be totally different, which obviously wastes a lot of time.
I think it's largely standardised now, and certainly I think I can't, again, I'll go back to the secrecy issue around of the Lighthouse Labs. We don't know what platforms they're using. My understanding is that they are what we call tooling up with more automated platforms that are less staff dependent, but actually we don't know, and we don't know what new platforms are going into the new Lighthouse Labs that are being designed in Loughborough and Newport. We have some rumours, but that's all. We don't actually know what they're going. But the packaging and everything, I think, is largely being addressed now, and we can move work around between Pillar 1 and Pillar 2 simply because we are using largely the same swabs.
When you talked about Pillar 1 leading, would you like to have seen that samples would have come in through the NHS, which would have meant we would have had one IT system, we would have had GP access to results, and then backup could have been used from university or Lighthouse based on the patient's NHS number, so totally confidential. Do you think something like that would be achievable now?
Absolutely. It might be difficult and challenging to retrofit that, but that would certainly be how we would like to see things. And that's how, if we started doing that from the beginning, we wouldn't have the majority of the IT systems that we're having now. Yes.
Okay, thanks, Alan. Rachel?
So just to say, I know that it must seem really, it's counterintuitive to imagine that we would want to have multiple different types of swabs and tubes. But this is a pandemic. It's not just affecting the UK. And so our sources of swabs and the tubes that they go in is extremely limited. We have had, as laboratory professionals, we've had to be hugely innovative, including in my own laboratory. Dr. Lisa Levitt came up with an extraction-free solution to be able to carry out COVID-19 testing without extraction reagent, which we could not get hold of during the first wave. That innovation has been crucial, as has a diverse supply chain. If we only said we're going to buy one set of swabs and then the company had a hiccup, then the entire country would not be able to test for COVID-19. So actually, for business continuity and resilience reasons, we need that diversity. And also because we've got a lot of innovation happening. So people are doing things in different ways, but that's bolstering our capacity.
And is it being shared? The new learning, the new techniques, with all this commercial hiding? Is there a forum within which you can all share your good ideas?
Absolutely. There is an innovations website, and people can upload their data, their findings, without having to wait to go through the full peer review publishing process. And also COVID-19 has increased the number of papers that are being pre-printed, which means they're being made available on an international scale before going through formal peer review. Now, you can imagine that has pros and cons, but most of us are able to judge wood from trees, and you can download those methods, try them in your own laboratory, and if they work, you're away and you've improved capacity and resilience.
Well, that positive note seems like a very good place to stop. And thank you so much, both of you, for giving us your time today and for staying 6 minutes longer than we'd advertised. But it was so interesting. And I don't know about my colleagues, but I certainly felt by the end of that, I felt I was getting somewhere in my own understanding of this, but also very heartened to know that you are there and leading from the front. And I thank you so much, both of you, for giving us your time today, but also everything that you're doing. Please stay in touch. Please let us know how it's going. Let us know how we can press. We will be taking your recommendations, which I think we're coming across loud and clear to us during this session, and pressing those upon government and getting answers. But if there are others that you feel you weren't able to get across, please do send those in and we'll include them. So thank you, Alan Wilson. Thank you, Rachel Liebman. Thank you all parliamentarians. Thank you for those who are watching at home and those in the gallery, as it were, who have been watching the session live. It's worth saying, just as we end, we had a huge amount of interest in this session. We received nearly 1,700 individual pieces of evidence from members of the public in the week prior, as we advertised that this was coming forward. It's clearly of great public interest. And so thank you all for your participation today. I hope we've given those people at home who've submitted evidence a glimpse into some of the answers that they're seeking. So thanks very much, everybody. And we will have another session again in 2 weeks' time on a subject that we have yet to decide. We'll have to see what life throws up. Thank you very much.